The viscosity is more. As you see, it's a gel-like substance supporting posterior structure. These two aqueous part, second one, the vitreous one, is more gel-like, but the anterior part has more fluid structure who lets the pressure of the eye, there is something named intraocular pressure, is controlled by that. Do you know the disease that the intraocular pressure is getting high and it could result in blindness? Have you ever heard of that? No, cataract, Abdullah, is that disease that this lens is not clear anymore, and there is some calcium sitting there on that part, so you can see while you look through the eyes of your patient, you can see some sort of unclearness, or it's opaque out there. But the disease that I want you to know was glaucoma. Have you ever heard of glaucoma? Yes, Abdullah, exactly. It's glaucoma. The intraocular pressure, the pressure of this aqueous humorous is going high. And when you measure this pressure, it's going to be higher than usual. So, yes, this is glaucoma. Okay, the physiology and function. As you know, phototransduction, the changing of the light energy to electrical signals, is related to retina. Retina is the place who is, it's a structure is for transferring those data. These nerves, optic nerve, send these messages to brain for visual interpretation. Light regulation, of course, is depends to iris and to the lens, to the pupil diameter. That it depends on the light outdoors. It will be something from 2 to 8 millimeter. Actually, when the light is higher, the amount, the diameter is going to be less. Why? Because this too much light can hurt our eyes. But when you are in a dark room, this diameter, the pupil diameter, should widen. It's going to be something around 8 millimeter to optimize visual performances during the, for example, night condition. You know that, don't you? This topic was familiar for you beforehand. Of course, there are some medications who can result in pupil different diameters, but generally it depends on light. Everyone, do you understand what am I saying? Okay, if there is any question, if I talk fast, or there is something you have never heard of that, ask the question, okay? Okay, thank you very much. Thank you, guys. Let's switch to the third function. It's ocular surface dynamics. You know that tear makes a film, and this lacrimation helps the system to control the tidiness, control the humidity, but we can use this ocular system, the tear and lacrimation drainage, as a place to drug delivery systems. You can use drops in your patient's eyes, and by that way, you go for topical usage, ocular usage of so many medications. Instead of giving antibiotics orally with such higher amounts, you can give just one drop of that specific antibiotics through the eyes. And so you will have much more less side effects and much more efficacy. For learning how ophthalmic devices working, it is important for us to review these parts that we did it together. Okay, we have something named macula. As you all know, it's the place of the starting of the nerve at the back of the eyes. This system, I mean macula, is the center of vision. It's a 5 millimeter region. I mean, the diameter is 5 millimeter in the central retina that contains the highest concentration of photoreceptors. These photoreceptors are responsible for color vision, for detailed perception of what you see through your eyes. So this is the most important part of the eye. If a diabetic patient lose these areas, photoreceptors, they could be blind. And as you know, diabetes is the most important reason for blindness during the life of the patients. At this center, I mean the macula, there are some fovea. Fovea is this place control the visual acuity. I mean, you can see with details with this place. This tiny area results in understanding of the facial recognition. For example, you look at a person, you understand is he sad, is he happy, by looking at the details of the face. And this is very important for daily life, because while you look at other people, you need to understand what is the feeling of them, how you should behave in this structure, and so on. So remember, it is an important part of our eyes. Okay, for the clinical significance, you must remember that macular damage will lead to central vision loss, and it's something like blindness. This region is mostly the primary target of your diagnostic devices, your therapeutic intervention, some sort of drug delivery system over here, and even surgical implants. Let's see the ophthalmic medical devices. We have so many vast materials, from simple corrective lenses to help us to see better, to sophisticated surgical robots that they are designed to diagnose, treat, or correct generally the ocular condition with good precision and acceptable precision. Okay, we have some sort of diagnostic instrument, we have some therapeutic systems, we have surgical tools, and we have implementable devices. For the diagnostic tool, actually you use those devices to measure, to access ocular structure, to see the function of the cornea or retina. For therapeutic systems, you have different type of treatments that the technology may deliver drug exactly to the affected tissue that it's the ocular system. Some corrective lenses also considered therapeutic systems, because instead of wearing glasses, you use these lenses in your patient's eyes to control the vision. Regarding the surgical tools, you have precision instruments enabling microsurgical procedures. For example, I guess, is there anybody in the class who have a LASIK or femtolasic procedure to omit the glasses? Me, myself, everyone, I had such heavy myopia, and then I have a femtolasic surgical procedure, so I can see without glasses afterwards. Unfortunately, something like 15 years after the 10 years, 12 years after the process of surgery, my eyes started to get myopia again. So I need glasses for seeing far objects recently more and more. And it is the possibility that you use this microsurgical procedure for cataract, you mentioned before, for visional problem of the diabetic patients. We call it laser therapies to control the damage into your patient's eyes. And also we have implementable devices that you put permanent or semi-permanent structure place in the eyes, like you change your patient's eyes lenses. For cataract, afterwards your patient generally has two um, synthetic lens in their eyes. Okay, uh, diagnostic devices can be some optical coherence topography that we call it OCT. We have fundus cameras that when you go to the ophthalmologist, they look through that cameras to your back of eyes. And you have tonometers that consider the intraocular pressure. And you have other devices to detect functional or structural malfunction that you cannot see by without those devices. The therapeutic devices are treatment focused technologies with, for example, excimer lasers for refractive correction. I told you, like mine, then I don't use glasses. Drug eluting implants that you can target drug therapy to a specific place in the eyes. And you have surgical instruments that help microsurgical tools like phacoemulsification system, I will show it to you, or vitreoretinal instruments, and some precision knives, little knives with a specific head over there in that knife to control the operation that should be done in millimeters, and that's very important. Okay, the global ophthalmic devices market is very big. It's $34 billion by 2026, and 6.5% of growth rate is there. So this is a good market share, and ongoing research because of the enough, and I could say even more than enough money into this business. It's very important that this robust growth is converging factors. Populations are getting older. Older patients may have more cataracts, more glaucoma. Age-related eye diseases are going higher. The number of people who have the diagnosis of diabetes are getting more and more each day. Diabetes may result in retinopathy. We also have growing myopia epidemic. Lots of people like me cannot see far distances without sunglasses, without glasses, or without lenses for surgical procedures, microsurgical procedures actually. And we have technological advances that may help us to minimally invasive procedures get substitute for those previous risky surgeries with several damages. And the access to eye care in developing nations is expanding. That's why the market is getting big and bigger, and it's an opportunity for pharmaceutical professionals to contribute in this market. Okay, let's start the diagnostic devices in ophthalmology. These devices were for accurate diagnosis of eye problems, enabling early detection and precise monitoring of disease progression. Optical coherence tomography or OCT is providing high resolution cross sectional images of retinal layer. This is the type of test that for diabetic patients, for patients with an eye damage, you send them to have an OCT. They go with micrometer precision, and this detection revolutionized the macular degeneration because you can see the first signs of this degeneration and you can control that. That's why diabetic macular edema and any damage to these systems can be detected sooner, and because of this sooner detection, you will help your patients not to get completely blind. They will lose part of this visual field, but not as dangerous as previously. So, optical coherence tomography is a very good device to control the system of macula and system of retina so clearly in micrometer precision. We also have AI-powered screening. Machine learning algorithms helps to control the photographs of the fundus, and we can detect the diabetic retinopathy and age-related macular degeneration sooner with better accuracy. These machines will help human specialists like ophthalmologists to have the best screening capacity. And also, we have portable diagnostic tools like smartphone based exophthalmometry or imaging devices that may help us to have better and better access to these detections. Okay, tonometry. Tonometry means measuring intraocular pressure. The gold standard is Goldman applantation tonometer. That this is the reference standard for IOP measurement, intraocular pressure measurement. So Goldman is the gold standard, Goldman is the gold standard. Okay, this device measures the force required to flatten a fixed area of the cornea, providing accurate intraocular pressure reading for glaucoma. You may go to ophthalmologist's office and they can consider your IOP with this device. Right now, there are some. This device needs a contact with eye. They put something in the surface of your cornea, or sometimes on choroid area, to help you to help themselves to measure the intraocular pressure. But recently, we have a modern alternative. It's non-contact tonometers that it use rapid air pulse to deform the cornea, and it measures how much pressure needs from this air pulse to give a deformity to the cornea. It enables us to quickly screen the IOP without even an ocular contact, because only the rapid air pulse is touching the head of the cornea. You should consider that these devices are less accurate than applantation, but NCT devices is a good screening tool, and it can be used more and more each day. But yet the Goldman applantation is the best one, because this tonometer consider the IOP with quite high accuracy. Regarding your role as pharmacist, it's very important that you know IOP measurements have some principles. There are two different type of devices. One of them use a contact with the surface of the cornea. The second one only use air pulse a brief air pulse to measure the IOP. The accuracy is more in Goldman applantation tonometer, but because there is no contact in non-contact tonometers, NCT systems, they can be a good alternative for those patients you don't want to have any contact with their eyes. After pressure calculation, there is another device that consider the visual field and analyze that and show the perimetry. Most of us have been done this test. When you go to ophthalmologist, then ask you to sit behind this device, and they will put the glasses of that device, I mean the holes for the eyes, and adjust it for your height, for the place of your eyes. They put it just right behind your eyes. We have automated perimetry these days that, as you remember, there is a house at the back of the device, and then it shows there is a little sound. They ask you to look at my right eye, look at my left eye. You take a look, and by that light stimuli, they will take a look and see how is the perimetry of your eyes. We also have pattern recognition software algorithm, identify characteristic defect pattern, and specific pathologies on diagnostic accuracy. We generally may use this pattern recognition in those devices too. And we also have progression analysis. There would be a serial testing that you consider the difference of these tests to see the progression of how it goes for your patients. I mean, is there any need to intensify the treatment, or everything is okay? That was the diagnostic tools. Now we are going to therapeutic ophthalmic devices. It is not used generally for diagnosis. It's a way of giving important and topical treatment to the patient's eyes for correcting refractive errors. You can use that it will be lenses. For managing intraocular pressure, you may use it. For delivering sustained therapeutic agent, you may use it to control the diseases in that tissue. Okay, look at the contact lenses. They are nowadays beyond the vision correction. The traditional application, the contact lenses were primarily for refractive correction. The millions of people use them not to wear glasses. They put these lenses into their eyes and they don't need any glasses afterwards. They had soft hydrogel, silicone hydrogel, and rigid gas permeable materials for the different corneal geometries and physiological needs. Nowadays, we have therapeutic innovations. Excuse me. The drug delivery platform lenses can help us to provide some sort of drug release in a sustainable way to the eyes. So it's not just the lens for correcting myopia. It's a kind of lens who releases medications to the eyes. Myopia control is still a good facility for this. We have dual focus and defocus incorporated lenses that, for example, those people who have glasses for studying, when you are getting older, you need to wear some glasses for studying. It means that for seeing nearer objects, you need help. Maybe this patient will need glasses for far distances. These dual focus lenses may help them. For the child with laziness of the eyes, you use this to elongation of the eyes. For some sort of, if you use these lenses for the child, you may control the progression by 30 to 60%, and it's a high amount actually. So myopia control could be very good matter that be covered by lenses. You have also bandage lenses protecting the healing of cornea epithelium after an injury, after a surgery, because there is a incision in your patient's eyes. You use this lens to control the pain, to control the infection, to control the problem over here. And we also have prosthetic lenses that are cosmetically improve appearance of disfigured eyes. For example, your patients may have an accident and lose part of their eyes, or their eyes are not looking very well. After using this prosthetic lens, you cannot see the appearance of that disfigured eyes, and it helps your patients a lot. It will help their self-esteem and feeling better, not to feel ugly to the others. Lenses are not only contact lenses that you put the lens inside your patient's eyes. There are some intraocular lenses. Of course, you put them into the patient's eyes with surgical procedures because you implement that lens in your patient. It's intraocular lenses, not contact lenses. The material was polymethylene methacrylate, PMMA, that they had rigid lenses largely replaced by foldable acrylic and silicone materials. I will show you. Enables small incisions and faster recovery after cataract surgery. You bring out the disrupted lens, and you put this lens with a little incision from that place inside the eyes. We also have optical designs like monofocal intraocular lenses that provide excellent distance vision, and also it's multifocal, and it can be controlling the depth of focus, designed to reduce spectacles dependence by controlling the function of visions at multiple distance. So your patients should not change the glasses when they look around or when they look far. You have to remember, we also have a specialty functions. For example, you have some sort of intraocular lenses to help natural focusing ability with a design that is an innovative one actually. You have some lenses to control the blue light filtering lenses. They don't let blue light go in to protect retina from phototoxic particles of the radiation. We also have some sort of stents and drainage implants. Yes, guys, the stents are not going inside the heart only or brain only. But imagine the stents that they are going to the eye system are very fine. They are so little. This is the MIGS revolution. It is micro-invasive glaucoma surgery that is a paradigm shift in glaucoma management. It helps by this stent, you can open up the place that send the fluid out of the eyes, and it's help reduction in intraocular pressure and help your patients by the traditional filtration surgery. We also have eye stent technologies, titanium micro bypass stents measuring just 1 millimeter, create a very good pathway, a permanent one, through the trabecular meshwork enables aqueous outflow. So this is a sort of filter, doesn't let that outflow to close, and this outflow helps the water to go out. I mean, by water I mean the fluid, the eye fluid out, and that's why you can control the pressure of intraocular system. Of course, it helps us to achieve the target pressure to the amount that we want. We also have Hydrus microstent. These scaffold devices can help us multiple hours of Schellem canal. Schellem canal dilating with this drainage pathway and provides sustainable IOP reduction. So, of course, it had larger footprint because it depends on the anatomy of your patient. What does this microstents do? These scalpel devices put inside and open up the Schellem channel very well. We also have traditional drainage implants that there are some devices for glaucoma that they are for old days, but still it helps to shunting aqueous humor to subconjunctival reservoir. It's like a tube. It sends the fluid from this place to that place. So it doesn't, like a stent, it doesn't open up the area. It's a tube who send the fluid from this place to conjunctival places, subconjunctival reservoir, and helps to bring down the pressure of intraocular system. Okay, we also have some surgical instruments for sure. They help to control and have a better ophthalmologic surgery. They are helping us to have extraordinary precision standards. The devices are so much better. If these devices were not here, we had a lot of problems with surgical procedures of the eyes, and they're going to be better and better because they should work in a micron accuracy level. Can you imagine? Not millimeter, even micron accuracy level. So it is very important to have enough accuracy, and newer technologies can help a lot. Do you remember we talked about different type of knives? Take a look at this picture. Common surgical tools. One of them is side port entry blade. This creates a 1 or 1.5 millimeter corneal incision. So 1 millimeter or 1.5 millimeter incision that you can use this place to instrument access during the, for example, phacoemulsification. It's a type of surgery. The angle design enables controlled entry because of the specific shape of this side port blade, that it will lead to self-sealing architecture. So this is the specificity of this type of surgical blade. We also have the second one, it's chrome. It is a diamond or metal chrome. Of course, the diamond one is much more expensive for sure. Let me close the WhatsApp because it hurts a lot. Okay, diamonds are very expensive but very good accurate, and metal ones are generally okay. They create about 2.2 to 3.2 millimeter clear corneal incision for cataract surgery. For side port, it was 1 to 1.5. For chrome, it's 2.2 to 3.2. The blade's geometry produces architecturally stable, self-sealing wounds that minimize astigmatic changes. So the benefit is this type of surgical device will minimize the astigmatic changes in your patient's eye. Look at the last one. It's crescent knife. It's a curved blade. Look at that. The blade is curved. This can result in corneal tunnels with controlled depth and length that is essential for creating entry sites that balance the structural integrity and surgical access. These these three types are very well and now very well used in our ophthalmology surgical procedures. Okay, we also have scissors and forceps. Of course, they are in a level that you use them for ocular systems, and they should be very fine. We have one intraocular lens holding forceps. These forceps are very delicate ones, and they are not foldable. They put the intraocular lenses during the implantation or distributing the force to prevent optical damage. It's very important. These type of forceps need to be very well controllable without damaging the eyes. So it will help us to maintain the sterility during our surgical procedure with the least damage and best performance. The other one is capsulohexis forceps. This is a circular opening. Look at that. It's a circular opening in the lens capsules with controlled continuous tearing. It helps the continuous of the tearing, essential for a secure intraocular lens positioning and preventing of posterior capsule opacification. So it's another positive outcome. And we also have corneoscleral forceps. It's tooth-headed. The shape of these forceps are tooth-head, and it is for wound edges during without tissue slippage. It could help us for precision wound deposition and secure closure. So corneoscleral forceps are tooth-headed and they are used to control the wound edges during the sterning that you control tissue damage. Okay. We also have a specialized cutting instrument. You can see the scissors. Weker's scissors. DE is do, as you know, is French. Weker's scissors features sharp, fine tips for performing peripheral iridectomy. It's very good scissors, very miniature, fine, and sharp to control the system. It removes the small portion of iris to prevent angle closure glaucoma and angle closure actually. And this device, the membranes and adhesions during more complex procedures can be used as a specific scissors of the eyes. Do you remember from the beginning of this session we talked about phacoemulsifications? Its phacoemulsification instruction is a very good device for surgical procedure. You have an ultrasonic handpiece that it delivers high frequency vibration and results in emulsifying the lens. What kind of lens? Of course, you don't crush the healthy lens. Cataractus lenses. It crushes, it makes it as an emulsion, like a tiny fragments through the same instrument. Then you have the nucleus chopper. This is a mechanical place that mechanically divide the lens nucleus into smaller quadrant before emulsification. So this one make it chop chop, reducing the ultrasound energy needed afterwards for emulsification of that part. If you want to use only ultrasound waves, you're going to use a lot of ultrasound energy. But by using this nucleus chopper, you can chop the lenses into smaller quadrants, and then the emulsifier can bring it out easily. You also have wire vectors. This wire vectors retrieves dislocated lenses, or those parts are after emulsification and after the chopping. The nucleus fragments, anything that dropped post orientation and it goes back of the eyes, it could bring it out and prevent vision threatening complications. So you have something bring out everything as the wire vector. You have ultrasound handpiece to let the cataractus lenses go like emulsion, and you have a nucleus chopper to chop the part of the lenses. Okay, precision caliper application. Different brands are there, but one of them is the Castrovillo caliper that represents essential instrument, a very good measurement instrument in ophthalmic surgery, enabling surgeons for having a precision of 0.1 milliliter. Can you imagine? Of course, it's needed in ophthalmic surgical procedures, and you have to consider this as your part. The clinical applications include measuring horizontal cornea diameter for intraocular lens sizing calculation before the surgery. Then you determine a scleral flap dimension in the glaucoma filtration surgery, and then you plan for muscle recession distance for correction of strabism in the eyes. Strabism means when you look at your patient's eyes, you think that one of them looks at you, one of them looks at another place. Strabism means the two eyes are not in same direction when you look at them. Their scleras having the inappropriate angle to each other. And also you have accessing lesions dimensions during the tumor excision. Okay, so you have precision caliper applications for these type of measurements. When you properly and accurately consider the measurements of the eyes before the surgical procedure, you will have, of course, a better outcome after these surgical procedures, for sure. Okay, guys, maybe you're tired, and you have the right to be tired because we talked fast and fast afterwards. Are you okay? Are you still alive? Is there anybody feel okay? Okay, one. Bilal, at least you are alive, and Fatima is also alive. Okay, rest of you are sleeping. I guess my voice without my face is going to be terrible. Thanks for being alive, guys. Khuda shukr, Abdullah, Nida Azhar. Okay, very good. Let's continue. We are going to talk about ophthalmic drug delivery system. You want to have dinner? Okay, very good. Bilal, can you eat the dinner behind the laptop? Of course you can. I am the only person who cannot drink water, or somehow you just finished, so very good. So you're going to sleep, of course, after the dinner. All the blood flow is going to your GI system, and there would be nothing for your brain, for your eyes, for your ears. So it's going to be rest. Very good. Because I want to finish sooner, I'm sorry, but I will continue. Are you okay to continue? Okay, very good. Bilal is okay. I guess the rest also. Fatem is okay. Okay, very good. We're going to continue. Thanks for your responses. At least 4 people are with me. We're going to ophthalmic drug delivery systems. You put the therapeutic agent by these devices for ocular uses. So ocular tissue will have the drug over here. The eye's protective barrier limits drug penetration when you use the drug systematically. But when you use it topical in the eyes, I mean the ocular devices, there would be very better bioavailability. Of course, when you give the medications, the barrier is very protected, and also you have rapid clearance mechanism, and this also results in the reduction of bioavailability. That's why there are innovative delivery devices to overcome these obstacles and enhance the treatment efficacy. For example, conventional drug delivery or eye drops and ointments. There are solution and suspension. Their advantages was easy to instill, rapid onset. Patients know them very well and they're not scared of them. And they're cost effective. They are not that much expensive. But the disadvantage is poor bioavailability. Only less than 5% reaches the target. They needed frequent dosing. The preservative will result in toxicity concern, and some patients didn't use them very well, so you had compliance challenges. But regarding the ointment formulation, they will have a prolonged effects. Why? Because the prolonged corneal contact time helps them to stay there longer than the fluid actually. There will be a protective ocular surface coating, and there are generally preservative free options also. But the disadvantage is when you use an ointment in the eyes, you have blurry eyes. Vision blurring during the applications, you use them at night and you ask the patients to put them in their eyes and then go to sleep, because if they still stay awake, they cannot see. There is problems with their visual field. There would be visual blurring. It's difficult to instill precisely. It is less cosmetically acceptable because it's not the solution in their eyes. It's a ointment, actually, an ointment in their eyes, and it is having a risk for bacterial growth over there. That's why these are the advantages, these are the disadvantages. You need to know them all. Remember that 75% of the drops will immediately drain through the nasolacrimal system, so your patient doesn't have the drop in their eyes and they will have it in their nose or some sort of trachea in the GI system afterwards. You feel like some sort of bitter taste at the after the eye drop usage, you feel the bitter taste by yourself in your mouth. Okay, these were the conventional ones, the previous and traditional ones. Right now we have advanced delivery systems like gel forming solutions. This innovative formulation actually have some low viscosity solutions at the bottle, but when they go to the eye, this solution will change to gel. And this gel will have longer contact with the tearfil. That's why this gel matrix adhere to the ocular surface, and of course it expands drug delivery residual time. So it's a very good idea. This gel forming solution, it's a solution. When you use it in the eyes, because of the pH difference, it will change to gel. They are dependent to pH. So this pH trigger the gel formulation. Also temperature sensitive. So it's polymers like carbopol, ploxamer, and it will go to the physiological condition, transforming into semi-solid gels and release the drugs gradually over hours. We also have ophthalmic inserts. It's a polymeric device placed in the conjunctival sac, provide control and sustainable release of the drugs over days to week. Can you imagine? Little by little, for days and for sometimes for weeks. It's eliminating the need for frequent instillation of the drops. So it's also very good option. The key advantage is predictable drug release kinetics, because you put this structure in a specific systems. It improved patient compliance through reduced dosing frequency. It also enhanced bioavailability via prolonged corneal contact and minimized systematic approaches because absorptions, because you use it in the eye, so it minimizes the systemic side effects of those products. What type of ophthalmic insert do we have? We have insoluble insert. Of course, they are not biodegradable. There are some sort of polymers that you should remove them after the drug was eluted. Okay, the early systems were like that. You need to manually remove after, for example, 1 week of pilocarpine delivery. Then we have soluble inserts. They were water-soluble polymers that gradually dissolve and release the drug at the matrix and disintegrate afterwards. So there was no removal needed. So it's better. It is more acceptable by patients. Then we have bioerodible inserts. Bioerodible are biodegradable polymers like PLGA, collagen, and they are enzymatically degraded into non-toxic metabolites, and they can go out of the body by changing to these metabolites, combining sustained release with complete elimination. So the third strategy is also very acceptable. We also have osmotic inserts. Utilize the osmotic pressure gradient to control drug release rate independent of environmental conditions. It's just as a response to the osmotic pressure gradient, achieving zero order kinetics. It means that the delivery system has a completely slow and predictable kinetic. And at the 5-step, we have diffusion-based systems. Drug molecules diffuse through polymer membrane or matrix following Fickian kinetics with release rate determined by membrane characteristics and drug properties. The clinical note is, for example, pilocarpine Ocosert for glaucoma is no longer marketed. It was the first sustained release ophthalmic drug delivery systems that helped the patients for feasibility, 1 week controlled release system, but because you need to remove it by manual system, it doesn't exist anymore. These are different types. Actually, students, 1, 2, and 3 is more questionable. Do you understand what am I telling you? Mohammed, right now I have seen your comments. Blurry vision after ointment is generally for a couple of hours. So when you use the meds at night, in the morning, when they wash their eyes, it would be okay. Bilal, I said number one, number two, and number three, and also the pink dialogue at the end of this slide is much more important for your exam and for your questions. Okay? Okay. Okay, for mucoadhesive polymers, they are mucoadhesives. They will have the adhesion to the mucous of the eyes. It's very good a strategy in ophthalmic delivery, of course, with its specific cancer. It will enhance ocular residence time because it's mucoadhesive polymer from non-covalent bound with mucin glycoprotein in tear film. It will stay there, the formulation in the eye surface, in the ocular surface, and resisting drainage clearance mechanism. For the adhesion, you have polymer hydration, exposes adhesive functional groups that interact with mucin molecules through hydrogen bonding and electrostatic attraction. So they will stay there. The residence extension depends on mucoadhesive forces counteract tear turnover. They will stay unless your patients have tearing, but it will stay for some amount of time, extending the precorneal resistant times for minutes to hours. It's good for staying there for minutes, specifically for hours, depends on the type of the medication you use. And it also enhances the absorption. Prolonged contact increases corneal drug flux, improving bioavailability and therapeutic efficacy. Common mucoadhesive polymers are chitosan, carbopol, hyaluronic acid. You know that very well because it's a naturally occurring glycosaminoglycan, and also hydroxypropyl methylcellulose, HPMC, that you know from your pharmaceutics. From here, you can see the innovations in ophthalmic devices. Guys, innovations are not coming into your exams. I just put it for you to get more familiar with the upcoming systems, but it's not in your exam, so we can skip it. For this part, okay, very good. You're happy, okay? Innovation in the ophthalmic devices. I want you to take a look at the AI and digital diagnosis systems. The clinical impacts were very good. 87% diagnostic accuracy, 90% more sensitivity by the help of the new technology. Preservative-free multi-dose eye drops are in the market. It will come. Yet we don't have them in the Iran market. But remember, there would be very good systems because instead of the traditional multi-dose eye drops that they needed to have some preservatives to stay healthy for 1 month, and they need some antimicrobial agents to prevent the contamination. This bottle design is a sterile system that is squeeze actuated dispenser, so it doesn't let anything to go in. And it also has some silver ion antimicrobial systems. It will help the maintenance of sterility without using any preservative. It's very good, but yet we don't have it. And just I want you to know that it could be helpful. Intravitreal injections are also very important. There would be some systems, we yet don't have them that much, but in the market of the world, we have this different formulation and different type of So, laser in cataract surgery also is a new system that we also have them in Iran, but I don't want you to memorize all of them. Okay, this part, the new modern systems stops, we go to regulatory and manufacturing insights. Of course, when you work in the medical devices of ophthalmic system, you need to navigate the complex regulatory. And of course, it's complex because it's about eyes. Everyone loves their eyes. They don't want to lose any, they don't want any problem in their eyes. That's why the regulations are quite hard. We have FDA, we have CE market, European Union, and we have CDC, CDSCO in India, that they are the regulations. You need to be familiar with them. These are the regulatory classifications that observe and supervise ophthalmic devices and ophthalmic system. For the manufacturing processes, you need to know that these manufacturing technologies are very concise, and the machines, the injections, the casting should be very quality assured. That's why the regulations are so taking hard on them. We also need clinical trial for these devices, and it's a unique challenge in device studies because you have pediatric population, you have extended follow-up requirements, you have control group selection, you have subject endpoints, and having clinical trials in these devices is quite serious. I put one case study for you as myopia control lens trial. You can take a look at that to see you give the best medical device to the child, and then you follow up them. Is there any reaction? Do they go well with their lenses? And then you take a look at interim results and real world evidences. It's just an instance. In Iran, generally, we don't go for that. People come to pharmacy for some sort of lenses, and you have to tell them about the accurate method of using them. Okay, this is an important part, clinical application and patient care. Pharmacies serve as accessible healthcare provider. You are the most accessible medical providers, so you have a very important role in patient education and adherence support and adverse event recognition of these medical devices. Let's review what can be our role. First of all, for proper eye drop installation technique, you need to simplify the instruction and show them how to do that with very patient behavior and also very informative and clear language. You should give this proper technique. Wash your hands thoroughly before handing the bottle. Then tilt head backward or lie down, looking upward. Then pull lower eyelid down to create a pocket. Then position bottle above the eye without touching ocular surface. Then squeeze gentle to release a single drop into the pocket. Then close your eyes gently for 2 to 3 minutes while applying punctual occlusion. There could be also just the closure. It's okay. When they close their eyes, it could be okay. Avoid blinking or squeezing eyelid. We have some patients, they think that they need to squeeze their eyelid. No. They need to just rest in peace, which if they squeeze, it will expel the medication from that. So it is an important part of your job for these systems. For contact lens, of course, you need to tell the patients very carefully, because sometimes they buy the lenses from you from the pharmacy. You need to insist on hand hygiene before lens handling, proper lens cleansing, and disinfection protocols, like using the appropriate solution for taking care of the lenses. Appropriate solution selection. There are some solutions with multi-purpose systems. There are some solutions for hydrogen peroxide systems. There are some solutions that they are not even at the hand of the patients. The patient should give the lenses to the company, and they will disinfect the lenses for them with hydrogen peroxide or whatever. Afterward, they need to control the hygiene of the case of the lenses. You see that each lens pair should have a case for their replacement. The case hygiene also is very important, and you need to reschedule. Schedule the replacement of the lenses into that cases. You need to recognize warning signs. You tell the patient if you see any redness, any pain, any discharge, any vision changes, you need to stop the lens using and go to a doctor. An ocular specific center like in Tehran, Labafnejad, Farabi, those specific places that have ophthalmic ward, because there are specific, as you see, specific devices to have physical exam of the eyes. Never sleepings in lenses unless this lens is approved for extended wear. This is very important. They don't consider this serious, but it's very serious. Is there anybody in the class who use contact lens? Is there anybody in the class who use contact lenses? Hey guys? No? Okay, I want to ask those people if sincerely, do you bring out the lenses at night, or sometimes you feel sleepy and go with the lenses to bed? Fortunately, you all said that you don't use contact lenses very well. It's even better. Okay, we have some sort of side effects, some sort of complications. Sometimes it's device-related adverse events that requires attention. For example, for contact lens, you can have microbial keratitis. It will lead to redness, to pain, to photophobia, and discharge. And this is a very sight-threatening emergency that the patient, as I told you, should, as fast as possible, go to ophthalmology ward to control the lens discontinuation and control the keratitis very well. Okay? You also have post-surgical inflammation. Physicians generally ask them to come to doctors so soon. Usually they use, after the surgical procedures of eyes, they use topical corticosteroids with eye drops, and they control and they see if there is a worsening in vision loss or pain or any situation. They will consider a specific treatment like endophthalmitis or a surgical emergency procedure as soon as possible. Sometimes it's a glaucoma device malfunction. For example, you see a sudden elevation in IOP and it shows you that a stent placement was not okay. The stent was not properly positioned, or it redispositions. Patients have severe headache, eye pain, vision deterioration, and they need the same day of ophthalmology evaluation to see does this stent work well or not. And you also have intraocular lens dislocation, sudden monocular vision. You see that one of your patient's eyes cannot see or cannot see clearly. It may be a repositioning of the intraocular lens. After cataract surgery, after any surgery with intraocular lens, you need to consider subluxation or dislocation of these lenses, and then you need to as fast as possible reposition or exchange the intraocular lens. The role of the pharmacy in ophthalmologic devices is patients counseling. You have to know everything, or you have to guide your patients very well. You need to consider your duty regarding ophthalmic devices too. You can optimize your patient's adherence by proper information, proper description, and guidance. Your patient may have better tolerance. You can provide practical solution for any challenges that your patient doesn't like regarding their medical devices in their eyes, so you can optimize the adherence. You have drug device interactions sometimes. For example, because of the contact lenses, your patients cannot use some sort of eye drops or some sort of medications that are contraindicated with the contact lenses. You tell the patient, sometimes you ask them to use preservative free formulation with the lenses, and sometimes you put a time distance for multiple topical agents. You ask them to use this and then the devices and so on to control the situation. If there is any adverse effects, you need to help to recognize it, and you need to warn the patients about the warning signs and the referral signs, and urgent evaluation is your recommendation over this situation that we have been through it. Okay, regarding the future trends and emerging technologies, we said you don't need to read them, and it's only for your further reading. Nanotechnology, genetic engineering, digital health platforms will change and revolutionize these treatments, and it goes fast and fast. By nanotechnology, you can have nanoscale drug carriers and help a lot, because eyes are very little system, and these nanoparticles can help to have much more better bioavailability over there. Wearable and smart optic and ophthalmic devices are getting in the market. You don't need to study them for your exam, because not yet they are not, but it is for further reading. If any of you are interested in having a company with ophthalmic medical devices afterwards. And gene therapies and retinal implants are on its way. They are coming, in different therapeutic systems. Maybe you have gene therapies. Generally, there are more for other part of the bodies, but for gene therapy drug delivery systems to eyes, we also have some sort of recent FDA approval for inherited retinal dystrophies, that this will help to control this some sort of impossible for cure previously. Right now, you have a gene therapy that help your patients to control the situation. And remember, you need to have the sustainability and environmental consideration. Whenever you can use biodegradable materials, you should use them. Whenever you can use preservative-free formulation, you should use them. You should reduce the packaging waste, because plastics are not going anywhere and it will result in global warming. And also, contact lens recycling programs is very important, like other medication and medical devices recycling programs. So remember, ophthalmic devices, like as any sort of other devices, may result in an ecosystem danger, and we need to consider single-use devices, preservative-containing bottles, contact lens packaging can result in danger to the system, and sustainable alternatives are better. Guys, it will be in your exam, because guys, you don't have my voice? Okay. Thank you, guys. Thank you. I was worried if my voice is clear for you or not. Okay. As I told you, this slide is important for your exam because sustaining the environment is very important. Okay. This is the summary of this session. We talked about the device diversity. I told you you have medical devices for diagnosis in ophthalmic system. You have medical devices for treatment, that was surgical or drug delivery system, and you have medical devices for putting in, for example, intraocular lenses to correct the situation of the eyes. We have innovation, we have pharmacist value in the drug therapy of the ophthalmic devices, and we have regulatory rigors that it is very strict because eyes are very important over here. Everyone, look at me. The eye sees only what the mind is prepared to comprehend. This is very important. Of course, the vision and eyesight is very important, and empowering the vision care through knowledge of the ophthalmic devices is our value. I want to ask you as pharmacists to be very serious about your patient's eyes, help them to have the best outcome. Ali, I cannot send it to you. Send an email to me, then I will reply to the email with the slides because, first of all, I don't have the slides in this laptop system. I don't have my email and so on. Second, there should be an email to me. Everyone who has my email? Anybody? Abdullah, you send me a message. I guess you have my contact, okay? You send me a message and ask for the slides. I will